Hello everyone, my name is Negar Rostamzadeh, research scientist from Google. This work was in collaboration of a multidisciplinary team of researchers and with the participation of researchers and clinicians from a very wide range of expertise. Machine learning approaches are rapidly being integrated in health applications. Consequently, there are many concerns and risks identified that are associated with the use of ML technologies for healthcare as a high-stakes scenario. There are already many healthcare ethics frameworks and regulations. However, existing regulatory frameworks that could cover health data are limited in their applicability to the general use of health datasets for machine learning. For example, the Health Insurance Portability and Accountability Act, HIPAA, does not mandate ethics review for data collection and downstream use. HIPAA also places no limits on the use of de-identified data, regardless of who controls the information. The General Data Protection Regulation, GDPR, and the California Consumer Privacy Act focus on notification, consent, and deletion rights. But this does not necessarily address issues about the ethical collection, documentation, and use of data. On the other hand, the ML fairness community already identified many issues with ML systems that are traced back to data underlying the development process of ML systems. How can documentation of data help with surfacing the issues? One of the pioneering work in data transparency is coming from the datasheet for dataset paper by Dr. Gebru, that's inspired by documentation in electrical engineering practices. With this work, our first goal is to contextualize datasheet for health applications. Machine learning community really likes the idea of generalization, building a model that works for all tasks and applications. However, in this work, we want to mention there are some drawbacks associated with having a generalized approach without considering the context, especially if you're trying to assess a system with high-stake context. To contextualize the datasheet, we brought together a team of interdisciplinary researchers with expertise in ML for healthcare, ML fairness, applied ethics, and human-centered design. With this group of interdisciplinary researchers, we co-defined notion of transparency and accountability for health context. After grounding our research on these definitions, we adopted the Healthsheet for an early version of Healthsheet that we call primary Healthsheet. Then we interviewed experts with a variety of expertise and also validated and examined Healthsheet by creating Healthsheet for 3 publicly available datasets, Mimic3, MSOAC, and Floodlight, taking notes of the process, limitation, challenges, as well as gaps in existing documentation. Participants of our interviews were selected from a wide range of expertise and knowledge, such as ML for healthcare, legal and regulatory expertise, clinical, product, and privacy. Through our set of expert interviews, we first identified documentation shortcomings in health datasets and the impact of these shortcomings on research advancement and equitable healthcare practices. We improved open and used the Healthsheet as a diagnostic tool for health dataset assessment. Discussed the necessity and limitations of our initial Healthsheet questionnaire, and discussed the potential incentives needed by dataset creators and curators to create a Healthsheet for their datasets. Finally, we made sure the corpus represent our interdisciplinary perspectives through deep qualitative engagement across many iterations. We found that the lack of centralized and comprehensive documentation increases the challenges that experts face when selecting and using datasets. Of many reported challenges, a majority of participants considered availability and clarity of metadata as one of the major challenges. For example, one of the participants specifically talked about entities to get in touch with and the kind of content to be acquired to minimize all the back and forth with dataset creators. The second theme of challenges brought up by multiple participants were around subjectivity and labeling issues. One participant mentioning this as one of the most challenging aspects of understanding datasets. Another participant mentioned gold standards and clarifying definitions, annotations, and labels within datasets. For example, they mentioned how is a heart attack defined? Is the blood test or by symptoms? They continue by mentioning the huge amount of subjectivity and inclusion criteria that may exclude women and ethnic minorities. Other participants highlighted the disagreement between doctors and how this is interpreted with the labels. The third highly cited challenges mentioned by the participants were around inclusion criteria and accessibility. For example, people under 18 may be excluded from the dataset, and it's very important to have access to such metadata. Another participant brought an example about hospitals and the fact that many hospitals may just accept patients with referrals from certain units. Which all these examples highlight the need to clarify inclusion and exclusion criteria. After discussing the challenges faced by dataset consumers, we posed questions about the utility of Healthsheet to tackle the specific aforementioned challenges, as well as general issues concerning the use of health datasets. All participants stated that they would use Healthsheet if datasets were accompanied by them. The most common utilities of Healthsheets reported were understanding nuances and limitations of datasets prior to their use. When we have access to metadata and have clarity around nuances of a dataset, it could lead to identifying the limitation of a dataset. Particularly, one participant said, it feels morally easy to say that all datasets should cover everyone in the world in a fair and equitable way. And there is some truth about that. But there is also practical real-world issues to deal with. And it's okay if datasets are not fully representative as long as you know that from the beginning. The second general theme was around efficiency and ease of use of datasets. For example, if a dataset is created over a span of 30 years, if there are not enough metadata associated with it, the data could become very difficult, if not impossible, to use. So it's extremely important to provide as much as nuanced metadata to keep the dataset useful, even after a very long time. Besides discussing the benefit of Healthsheets for dataset consumers, an important step is to investigate potential incentives that can encourage dataset curators and extractors to create Healthsheets for their datasets. The subjective nature of incentives was a reported theme mentioned by several, largely dominated by a discussion of the trade-off between the perceived effort and time required in creating a Healthsheet and its impact. For example, one participant said, if I've done a lot of hard work in releasing datasets, it's fair to ask me to create a datasheet. One participant described a long-term gain over time from reduced overhead as a result of a one-time investment in the creation of Healthsheet as a peace of mind for dataset creators. But one very important theme that was brought up was around standardization and regulations in near future. There are not enough standardization around creation and use of healthcare ML data. But how about in 5 to 10 years? This is a huge incentive that led many dataset creators to think about the broader aspects of caring about metadata even now. As the original datasheet paper mentioned, these datasheets are meant to be created and thought about from very early stages of planning the creation and collection of datasets and meant to be a guide to better and more inclusive process. We as a community could also help incentivizing dataset documentation and sharing. This is not only about health data, but more general in ML community. We as a community should value creation of good quality datasets and benchmarks that's made publicly available for the community. Specifically in healthcare, there are many datasets that are not shared with broader research community, and maybe there are not still enough incentives to do so. NORIP's community contribution on creating benchmark tracks and encouraging the creation of datasheets is a good stepping stone towards incentivizing these processes. Relying on literature, interviews, and or case studies, we discuss the following aspects that should be expanded and discussed in health context. Multiple healthcare datasets, specifically datasets created using mobile apps such as Floodlight, are dynamic, meaning a new version of the dataset could be available in a short span of time. For some datasets, multiple versions of the same datasets may be released, so it's important to keep track of the properties that evolve with time. In the same way, coding documentation is a living artifact, and here we added a category of questions related to data versioning. As we discussed, one of the most cited aspects that was addressed during the interview process was inclusion criteria. It's important to know who is involved in the dataset and how. Racism and social conditions have had a fundamental impact on causes and prognosis of many diseases throughout the history. This has been increasingly evident during the COVID-19 pandemic. On the one hand, given that sociocultural factors can significantly affect the healthcare conditions of BIPOC population, collection and access to demographic information is critical to conducting fairness analysis of ML healthcare models. On the other hand, modern American medicine has historical root in scientific racism and eugenics movement, and racialized conception of susceptibility to disease persists to this day. With medicine, there is no uniform practice regarding the use of race as a study variable, and little to no exception that authors examine racism as a cause of residual health inequalities among racial groups. Likewise, for ML, there is no uniform practical guideline regarding the use of race as a variable in predicting models or datasets, nor is there an expectation that ML researchers examine structural racism as a cause of health inequalities among racialized groups. Due to these historical and structural reasons, great care must be taken when collecting and using demographic information, and specifically race, in healthcare datasets. So questions around this topic is discussed in Healthsheet. The modality of datasets refer to the different type of data it contains. Depending on the domain, healthcare datasets are created using a variety of devices and equipment. These devices come in various forms, ranging from large machine learning machines located in the hospitals like MRIs to small-scale wearable devices like smart health trackers. Modalities not only govern the fidelity, but also the statistical properties of the dataset. Hence, it's very important to capture the details about the modalities of datasets. Subjectivity issues that was earlier mentioned was one of the most important issues specific to healthcare that should be discussed and addressed in data documentation for healthcare. Last but not least, when developing models for healthcare, it's crucial to understand what limitation they will have. Such limitations stem partly from data distribution covered. The narrower the data distribution, the more limited that use cases it could have. Finally, we would like to mention the Healthsheet doesn't mean to serve as the most comprehensive health dataset guideline for health dataset documentations. However, we want it to serve as initial point of discussions for on ML for healthcare dataset documentations. We want to restate that using a generalized framework without considering the context could lead to more inequitable outcome. So contextualizing datasheet for healthcare applications could actually address the contexts that are very health specific. Thank you.